Hello dear friends. This edition is meant for healthcare professionals. Today I will be discussing on the new molecule, the oral semaglutide. Before that, the revolutionary tale of GLP-1 receptor agonists. It was in the year 1964 incretin effect was first discovered. That incretin effect is diminished in type 2 diabetes. It took almost 3 decades, and that was in 1992 when GLP-1 was shown to reduce glucose in type 2 diabetes. It was in 2005 when the first glucagon-like peptide agonist was launched in the market, and that was exenatide, derived from exendin 4, and that was a discovery from the saliva of the Gila monster. And in 2020 we have several molecules in the global market. We have GLP-1s as once daily injections, as twice daily injections, and some of them are once weekly injectables. And among all these molecules, Liraglutide, that is Victoza, remains the global leader. It was in 2010 Liraglutide was approved by the US FDA and the DCGI in India. With the publication of LEADER, Liraglutide was established as a molecule with cardiovascular superiority. A molecule which can be used in the treatment of diabetes, which can be used in the treatment of obesity, which can reduce not only the major adverse cardiovascular events, but also can reduce the cardiovascular mortality. And in 2017, DCGI approved Liraglutide with an additional label indication for the cardiovascular benefits. Early in 2020, including in India, Liraglutide has been shown to be a very safe molecule, even approved for use in children 10 years and above with type 2 diabetes. Relatively very safe even in the presence of renal disease, and may be used in all ages. And we have also, from our country, we have published the evidences in real world life in new onset diabetes, and also as an add-on to the existing therapies in diabetes. But now let me take all of you through the journey of patient-centric approach to the clinical outcomes. Right from the beginning of discovery of insulin, within 10 years of discovery of insulin, there were publications on the first enhancer oral insulin and anti-protease insulin. But all these experiments and clinical trials miserably failed. But now we have succeeded. We have succeeded in overcoming the major challenges of oral peptide, and these are the limited bioavailability or permeability, the enzymatic stability, the effect of the food when it is ingested, and of course the proteolytic digestion in the stomach. And how was it possible? This was possible by co-formulating semaglutide with SNAC, and this has resulted in promoting the absorption of oral semaglutide across the gastric epithelium, and with the assistance of SNAC, it has enhanced the oral bioavailability of the molecule. And if your question is on semaglutide, this is the most powerful and this is the most effective GLP-1 tested till date, available till date, and previously only available as a once weekly injectable formulation. SNAC stands for sodium N82-hydroxybenzoyl aminocaprylate, which enhances the transcellular absorption of semaglutide. This is not the first time SNAC is used in a co-formulation. SNAC has been used along with B12 oral to enhance the bioavailability of B12. And in semaglutide oral, it is co-formulated, and in all the three strengths, 3 milligrams, 7 milligrams and 14 milligrams of semaglutide, you have 300 milligrams of SNAC along with it. When we are advising patients on oral semaglutide, it requires a little bit of training. They have to wake up early in the morning with at least 6 hours of overnight fasting, and then ingest the medication along with half a glass of water, that is 120 ml of water. And after ingestion of the drug, they need to be fasting for another 30 minutes, and they need to avoid any food or beverage or medications for 30 minutes after the ingestion of the oral semaglutide, and that is Rybelsus. And this is an animated slide to demonstrate the absorption of semaglutide. It is essential that the tablet need to be at the proximity with the gastric mucosa for optimal absorption. So once the barrier is broken, the components, that is semaglutide and SNAC, will diffuse with the solution. SNAC results in a local increase in the pH, and this helps oral semaglutide overcome the proteolytic digestion. It also, SNAC also reversibly increases the local mucosal permeability, and this results in an increase in the absorption in the transport of oral semaglutide across the gastric epithelium into the systemic circulation. Whatever semaglutide is left over is degraded in the gastric lumen. And this is how the two major challenges have been overcome: the proteolytic digestion and the limited absorption or bioavailability, thanks to the co-formulation with SNAC as an absorption enhancer. Now let us together travel through the journey of the clinical development program, and these are the landmark pioneer clinical trials to establish the safety and efficacy of oral semaglutide. There are a total of 10 pioneer clinical programs. From the earlier experience from the phase 2 clinical trials, 3 dosages were selected: 3, 7 and 14 milligrams. And remember, very similar to Liraglutide, you start with the smallest dose, and then each dose escalation may be executed at the intervals of 1 month or even lower if the patient is tolerating well. So this is an overview of the pioneer clinical development program, starting from patients who were only on diet and exercise to manage diabetes, all throughout the popular drugs, including the contemporary oral therapies, injectable therapies such as Liraglutide and basal insulin. So let us have a brief, a summary of whatever is required for a clinical practice about the pioneer clinical program. So now we will discuss pioneer 1. So these were subjects who were only on diet and exercise for the treatment of diabetes. So they were randomized either to semaglutide 3 milligram, 7 milligram or 40 milligrams or to placebo. And Pioneer 2 and Pioneer 3. And these were either with empagliflozin or against sitagliptin. The two oral therapy, the leaders in the world, the two type 2 diabetes oral therapy leaders, and that is with empagliflozin and sitagliptin. And Pioneer 4 is comparing this against GLP-1 receptor agonist, that is Liraglutide, and Pioneer 7 is again against 100 milligrams of sitagliptin, but this time with flexible dosing of either 3 or 7 or 14 milligrams. And this drug has also been tested along with insulin. Patients who were on insulin, and they were again put on the 3 doses and compared against placebo. And these are some special situations in those patients with moderate renal impairment, EGFR 50 and above, and then this was tested exclusively in a cardiovascular outcome trial. Now let me move on to the discussion on glycemic efficacy and its benefit on losing weight. So first of all, the glycemic control. So here you see the benefits of oral semaglutide compared against placebo, empagliflozin, sitagliptin, against liraglutide, the flexible dosing against sitagliptin 100 milligrams, and then those patients who are on insulin. The dark blue bars seen across the Pioneer clinical development program, they are the 14 milligrams, and the light blue bars represent 7 milligrams of oral semaglutide. So it is quite obvious that there is a clinically highly significant lowering of glucose, HbA1c lowering with both 7 and 14 milligrams of semaglutide against all its comparators. So what about the weight loss with oral semaglutide? That is very significant in the management of diabetes. So when you compare oral semaglutide against the comparators and placebo, there is a significant benefit with weight loss. And these are some of those examples: 3.7 kilograms weight loss with 40 milligrams compared to 1.4 with placebo, 3.2 milligrams with 14 milligrams of semaglutide against 1 kilogram weight loss with sitagliptin, and even against injectable liraglutide 1.8 milligrams, which has resulted in 3 kilogram weight loss. Oral sema, in contrast, has resulted in a phenomenal 4.3 kilograms weight loss. So this drug is definitely superior, both in terms of A1C lowering and in terms of weight loss, when compared to almost all the existing, all the contemporary oral and injectables. And with the percentage of those patients reaching an A1C below 7%, it's also significantly higher percentage, 77% with oral sema versus 31% with placebo. And with empagliflozin, one of the current leaders in oral therapy in type 2 diabetes, 66% of patients have reached with oral semaglutide an A1C below 7 versus only 43 with empagliflozin. And the same with sitagliptin, almost 3 times higher with the flexible dosing of EMPA compared to 100 milligrams of sitagliptin. A very common question when we are discussing a new therapy option for you doctors: when should I use oral semaglutide in my clinical practice? Whether I should be using it in early diabetes or in advanced diabetes, or in established diabetes, or in advanced diabetes with complications. And this is the robust data from the Pioneer clinical trials across all stages of diabetes, it has proven equivalent efficacy in A1C lowering. Another question, are there any differences between the races, between the ethnicities? And this is where I have divided into 3 ethnicities. I have the white population over there, and then the African Americans, and then the Asians. If I am to hide, so with the next click of the mouse, I am going to hide all the comparators. So what is left over there in the screen is all oral semaglutide. And if you compare with the other 2 races, there is a substantial significant reduction in the A1C in the Asian population. So across the placebo controlled trials, the Asian ethnicity has demonstrated a significantly better A1C reduction compared to Caucasians and African Americans. And that's going to be a very, very exciting news when we start using this drug in India. Oral semaglutide is already a DCGI approved medication in India. And now a very, very brief discussion on the cardiovascular safety. Pioneer 6 was meant for a regulatory approval, and in this cardiovascular outcome trial, 14 milligrams of sema was compared with placebo, and this was add on to the standard of care, but with very limited number of patients, and it was event limited, more than or equal to 122 first major adverse cardiovascular events. And of course, there were significant differences with the cardiovascular death and a non-significant 21% reduction in the major adverse cardiovascular events. The point to be noticed here is with the tolerance and adherence to the therapy. The vital status was known for 100% of the patients at the end of the trial, and with a very high retention and follow-up of 99.7% of the patients. Only to emphasize the significance of safety and tolerability of this molecule. So the patients have embraced this molecule as a safety and as an efficacious option in type 2 diabetes. But of course, we need a better and a dedicated clinical trial to prove the cardiovascular safety. And this is the ongoing SOUL cardiovascular outcome trial. Oral sema compared against placebo in close to 10,000 patients. A robust clinical trial, and it is powered for superiority with a duration of around 5 years to prove that oral semaglutide is superior in preventing the major adverse cardiovascular events compared to placebo. So in conclusion, I would say that good glycemic control is a dream for all the physicians and patients. And there are 2 challenges to achieve the goal: hypoglycemia and weight gain. Oral semaglutide results in less or no hypoglycemia, and that too with weight loss. GLP-1 receptor agonists, many of them are already an ideal choice, but none of them are now available as an oral formulation, which will enhance the acceptability of this molecule. Oral semaglutide has already shown its cardiovascular safety and is gearing up to prove the cardiovascular superiority. When we are gearing up to commemorate, to celebrate the 100 years of discovery of injectable insulins, oral semaglutide is an innovation with a great potential to pioneer a new era in achieving the targets with convenience of oral administration. So I personally believe that this lecture has been highly useful to all of you. Thank you very much for joining us today. Bye bye.